Right, good afternoon, everybody. I think we are just afternoon. I'd like to welcome you to the Health and Adult Social Care Scrutiny Committee this afternoon. We're going to do introductions later because I've got some housekeeping to do first. So a fire practice is not expected, and if the alarm sounds, can all present leave the building as quickly as possible by way of the nearest exit. The designated assembly point is in the public square in front of CAST, beyond the fountain and away from the civic office. If there's anybody with mobility issues, please wait in the refuge area at the top of the stairs where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. No roll call will be undertaken. Mobile phones, can I remind everybody to make sure that your mobile phones switch to silent mode, please. And this meeting will be audio-visually recorded and will be available to view on the Council's website and YouTube channel. Can I ask all those present to use their microphones to ensure the audio can be captured? Any members of the public entering the Council chamber are accepting that their images will be retained and broadcast by the Council. And if there are any public in attendance, if any member of the public or press is intending to record or film any part of today's meeting, please ensure this doesn't disturb the conduct of the meeting. And if you were visually recording, you are requested to only focus on recording. So if we start with any apologies for absence, we've currently got Councillor Laura Bluff, Linda Curran and Martin. I think we've had some additions. Yeah. Okay. And if we consider the extent, if any, to which public and press are to be excluded, I don't think we have any. Have we any declarations of interest? No. So can I have approval, please, of the previous minutes of our meeting held on the 21st of March, pages 1 to 8? Approved? Yes, thank you. And I don't believe we have any items where the press and public would be excluded.
No, and just going back to number 5, public statement, there's no public in.
Okay. Right. So if we start with introductions, so if you'd like to start first, Rachel.
Good afternoon, I'm Rachel Leslie, I'm Director of Public Health at Doncaster Council.
Good afternoon, Vanessa Powell-Hoyland, Public Health Lead at Doncaster Council.
Afternoon everyone, my name is Alan Wiltshire, I'm Head of Policy Performance and Intelligence.
Afternoon, I'm Laurie Mott. I'm a data analyst that works as part of the PIC team and have done some of the analysis that supports the JSNA.
My name's Glynis Smith. I'm the chair of the meeting.
Sorry, Councillor Sue Knowles.
Councillor Sean Gibbons.
So, good afternoon. The aim of the session today, we've been asked to come along with an overview of the JSNA and JSNA products, but also to give the panel some insight and some background to enable them to select their work plan for the year ahead. So the way that this will work is we've got a small number of slides. My intention is not to present them one after the other, but to provide them as a point of conversation. So if any members of the panel would like to ask additional questions or clarifications or initiate some conversation around any of the content of the slide, then please indicate to the chair and we can do it that way. I've brought with me Laurie and Al, who are experts around our JSNA, our Joint Strategic Needs Assessment, and I've got Vanessa with me as well, who has developed, with the Well Doncaster team, community profiles over the recent few months and year, and they are part of our JSNA product as well that enable us to view what's going on and priorities in particular areas. So with that understood, I hope I'll commence with what is a short number of slides and bring in colleagues where relevant. So health and wellbeing in Doncaster, and the overview that I've got for you and would have been included in the papers for today would have been a summary of health and wellbeing data and insight on where to find it. So JSNA information is available as a public resource on the JSNA website. There is a link to it on this slide and also in the papers that you've had in advance. And the JSNA consists of a number of products, so we keep up to date our demographic and other data under Starting Well, Living Well and Ageing Well. And we also have focused work programmes through the year that Laurie and the team work on. So you'll see there in the grey boxes on the screen on the right-hand side some of the focused areas of work or deep dive health needs assessments that have been recently completed. We also have special projects, as I like to call them, that happen each year. And in the last year, we've had the Fairness and Wellbeing Commission and the associated data walks as one of our special projects. And as I've mentioned just a moment ago, the Well Doncaster community profiles. So finding health and wellbeing data is a real rich source for Doncaster. I've taken the liberty, I guess, really, of suggesting some potential topic areas for the panel. And as well as presenting some opportunities around this, I have given a summary as well of some other areas that might be of interest. So you'll notice on here that these are broad topics. I've got a slide on each area that will suggest or give you some insight into why I think that would be a good topic area for the work programme for the panel. But broadly, it's areas where we've had a new service or a new specification, where we've got a recent or an impending deep dive needs assessment, where we've had fixed term funding, so we've had pots of additional national funding around particular service areas in the last few years, where we've got focus for our new health and wellbeing strategy or links to our ICP strategy as well. So that's given me this, this list of possible shortlist areas that you might want to focus on. So no JSNA presentation is complete without some graphs, and Laurie would be able to explain about the 3 points of a downward trend there on the side, so he can give us some more background to that if we want to hear that as well. And we've heard for some time in Doncaster around how healthy life expectancy, which is based on survey data, is low, particularly in Doncaster, but also that worrying trend of reducing over the recently most available data to us. I've highlighted some orange areas on the side there that, that the panel might be most interested in focusing on or having some more insight on the year ahead. And they are more around the lifestyle factors, so smoking, diet, substance use, but also around access to healthcare services as well. I also want to include to you a proposal around specific characteristics, so these might be around ethnicity or in the places, the particular places that communities live in as well. I'll also give you a chance to look at some of the other areas, so that income, education, social connections, those wider determinants of health, where we focus much of our energies and efforts too. So just working through these potential areas, I'm not going to read out all of the statistics on the side there. So these are taken directly from either the JSNA data that we've got, the Fairness and Wellbeing Commission resources and data walks, recent DPH annual reports, and also the community health profiles that we've used as well. Substance use I've proposed as a particular area of focus covering all areas of substances, so illicit drugs, alcohol, but also smoking. And this is for a few reasons. So we have a new substance misuse service working under a new specification that aims to be more focused on the wants and needs of people in Doncaster. So moving away from a transactional delivery of a service to a more relational delivery of a service. And that's a brand new specification that started in April this year. We've got in Doncaster, as all other areas have got as well, a local combating drugs partnership that drives the investment and approach around some new supplemental substance misuse resources that we're in the third year of, and this is potentially the last year of that. And that focuses around 3 priorities for reducing drug supply, cutting demand from younger people, and having a world-class service. And that's in response to the National Drug Strategy. What I would be most excited to demonstrate and to showcase to the panel is our lived experience in recovery partner, or LERO. So we have a LERO that covers Doncaster, and the aim of that is to get and bring in the voice of people who are in recovery or have recovered from substance use issues. And they work through things like the Sober Social in town and have had some real creative approaches to getting and hearing that voice and building that into our priority areas. And just to repeat as well, mention there that additional fixed term funding that we've had both for smoking cessation, which has kicked in for this year and goes on to the next 5 years, and around the substance misuse service as well that we're into year 3 of. And hopefully you've had a chance, as this has been on the screen, just to read some of the stats and details that is available through all the JSNA resources. I'll just pause for a minute in case anyone wants to indicate to the chair for any questions on that.
Could I, going back to the graph on the previous, yeah. Can I ask why the Doncaster graph goes so up and down when the countrywide graph is fairly stable? Do you know the reason for that?
Yes, so I'll have a go at answering, and then Laurie will give a much fuller version of it as well. So healthy life expectancy is measured using survey data. So a proportion of the population is surveyed, so asked a question, and then what's called life tables are used to understand what a healthy life expectancy period would be. The more numbers that you sample, the more likely you are to get, I guess, an even number. So that probably demonstrates the change in variation. Over time, we have had certainly reductions in life expectancy, so different to healthy life expectancy, both nationally and locally as well. And there's all sorts of different reasons behind that Laurie can give us some more details to. What's particularly troubling for me and for Doncaster is about that trend, so that real strong reduction over since 2014, and you might want to match that to other things that have happened in that time period as well, a raft of different things. But when you are asked that question, so actually I've been a person that's been surveyed with that question in the most recent just random drafting of that, and anybody that doesn't answer that their health is good or very good gets categorised in the poor health or okay category. So the smaller numbers, the more likely you have to have variation creep in, but it's still a data, still a stat to be concerned about. Laurie, do you want to add to that as well?
I'm not sure I can add a great deal in terms of how that works, but essentially it's related to the number of people you're measuring. The fewer there are, the more dynamic the line's going to be. So yes, essentially that's the problem. If the dots are red, that means they're significantly different. And no matter how much it's bouncing about, as you can see, if you look at the women's graph, which is the one at the lower one, you can see they've always been worse. It's just started to get even worse. That's the one takeaway from that. The other thing just to bear in mind when you look at those graphs, and it's a little bit difficult to see, and I'm always getting told off for this whenever I present this, is you need to look on the left-hand side at the scale. It actually goes from, bear with me, 54 to 64-year-olds. So what we've done, so in other words, if you were to do that from 0 to 64, the lines would be much sort of more difficult to distinguish. So because we've extended or narrowed the y-axis, it'll make the line seem a bit more bouncy. So it's partly the way we've illustrated it, just so you can see the difference, and partly because it is small numbers. I hope that's sort of made sense.
Yes, thank you.
I suppose I've become very much more conscious since becoming a member of a scrutiny panel around numbers that we use to do research. And I found some of the numbers, I have to admit, a bit of a shock, particularly when it concerns joint scrutiny, when you're looking at, you know, Doncaster, Barnsley, Rotherham and Sheffield, and the numbers that we've asked questions of are so low. I mean, minuscule. What can we do to address that and make it more of a sample, if you like, and how could we do that? How would we go about getting more people interested in taking part in surveys?
Okay, so a few things to answer there. When we present data, and much of what's in the JSNA will be based on national data reporting, and I guess Doncaster's slice of that. So as soon as you boil that down to a smaller area, you're more likely to see that variation. Research you've asked about specifically, so where there's, I guess, formal research happening, there would be, I'd expect there to be things like power calculations of how many people that they would need to include in that research, whether it's survey or other ways of counting, in order for the results of that research to tell us the story that's most accurate to what's going on. So that should be the research approach that we've got. Around how we gather our insight, whether it's through surveys or through other community-based approaches like appreciative inquiry, it's usually that more the better type focus. And I'll bring Vanessa in on the side as well, because she will give us some examples of how we've done that. So for us as a public health team, and I would expect across the rest of the council as well, that aim and focus would be not just the numbers, but also being able to get into particular communities who might have a different experience of whether it's accessing a health service or describing what their particular health and wellbeing needs are. So yes, numbers of people in a population, but how representative that is as well. Just one small example I'll talk about is the work that we've been doing around age friendly. So we had a really good response to that, but when we dug into the data and looked at the ethnicity data, as you'd expect, much of the focus was on white British people and very little on people from other ethnic minority backgrounds. So that gave us that idea to actually say, how do we work with those communities so we understand their perspectives as well. I'll just bring Vanessa in as well with some other examples.
Thank you. So as Rachel said, one of the things that we use is national data or different forms of data sets. The work that we've been doing around appreciative inquiry, and if you're not aware of the methodology, it's having strength-based conversations with our residents around their wants, needs and aspirations, but also we ask around what does good health look like to you. So where they may have completed a survey that, as Rachel said, that talked about the different levels of good health, etc., we actually in Doncaster every month have really rich conversations with our residents, that strength-based conversation, and asking them what does good health look like and what are the amenities in place that we can understand that enable that good health as well. So we have those conversations. If they feel that they're not physically active enough or they're not feeling well enough, we talk about how we can actually enable them and support them to be in their community and be active in the community. And the 4D approach of appreciative inquiry is discovering with our residents, but then dreaming, designing, delivering. So we listen and we hear what our residents are talking about, and then we help shape interventions. But the data sets that we look at, actually, we need to remember that that's quantitative, and we've got rich qualitative data that is about what our residents are telling us in Doncaster.
And just for the last comment on that as well, all of that is available. So the community profiles we'll hear a little bit more about later are all included on the JSNA webpage as well. And the data and insight that was collected for the Fairness and Wellbeing Commission, including the pen portraits that were created as well based on real examples of people living in Doncaster, they're all available for Team Doncaster partners or for anybody to use to understand our Doncaster populations. Okay, if we're ready then, I'll just go straight through the substance misuse one that we've covered and go on to the next proposed topic, which is health and well-being of women. So you questioned quite rightly earlier around that healthy life expectancy for women in particular, and that's prompted some focused work for us in Doncaster. So we are almost there with completing a health needs assessment for women. And I'll go down to the bottom one. So there's some national funding, only small amounts of funding around women's health and women's health hubs. For us in Doncaster, we've focused that on health inclusion groups. So for us, that's women from Gypsy, Roma, traveller backgrounds and sex workers. And then just the other element as well, you perhaps will have seen that lots of things are designed for men and not for women, including things like health services and dosages of medications and all sorts of things that are supposed to keep us safe. And equality and access to services and things to stay well, and women can experience a difference in their outcome or experience in services as well. And just as I've described that, you've had a chance to read down some of the elements that might indicate why we might want a women's focus as well, all the way from maternity services to what mortality rates that women are experiencing as well, and to poverty. So that around lone parent households, 90% of those in Doncaster are women, and 49% of them are living in relative poverty, and the impact of that on mental health. So I'll just pause again in case there's any particular questions you want to indicate to the chair for.
I have some very wide-ranging experience on health needs assessments for people who have experienced inequalities. When it's not a mandatory service, it isn't always done, despite huge amounts of work by different teams all over Doncaster. And I wonder how you're going to persuade our primary care colleagues to support that, really.
Sorry, my button's still on. So just to understand then, to persuade primary care colleagues to provide a particular service?
Yes, I suppose if we're going to address, a health needs assessment, and if we're going to address health needs of particular groups of vulnerable people, are we going to make that something mandatory, or is it something that we're going to get funding for, or how are we going to address that?
Yeah, so there's a later slide coming up as well around other inclusion health groups that will describe what other kind of inclusion health groups that we'd have in Doncaster as well. So we might try and answer your question in a different way on that too. Just around when either we have new services or new things, what some of the considerations we're required to undertake, some of the processes. So things like equality impact assessments should be done on any new services or revised as well, to really understand should particular groups, whether that's women or other inclusion groups, have issues or need to have additional allowances made or services promoted in different ways to enable them to have the same access as what you would call a general population. So I'd hope that it isn't so much a task of persuading, but would be a duty of all of our health service colleagues around how they ensure that services are available. The bit that you said around additional funding, so the national funding for women's health hubs I mentioned earlier is a small amount, but has been available across the country and was allocated in place areas. So that went to South Yorkshire, and we in Doncaster made the first proposal against some of that. So we've secured some of that funding for those two projects that I mentioned, the sex worker one and the Gypsy Roma Traveller Women one as well. And Vanessa's going to come in and remind me of one of the tasks. Go ahead, Vanessa.
No, Rachel, I was just going to talk about some of the work that's really important that Well Doncaster's been undertaking is that, so when we talk about mandatory screening and things that, actually it's not mandatory, but it's choice, but what also we find is that our residents are not finding that the current services might be right for them. And the work that we've been doing is actually finding places in the community where they may be able to undertake that screening or may be able to undertake that service. So that actually we know for a fact that listening to our residents that not all clinical services need to be in a clinical venue, and they can be in other places. And that's something we've been doing. And I'm just going to talk about the Women's Hub. So that work that we've been doing around women being able to go to changing lives in a clinical space, but actually not in a clinical venue, and that opportunity, because we know that the stigma for some women or for some residents is actually going into that clinical space. And so it's really important that we have community health in our community, so people can go and feel confident and feel comfortable in where they're having their appointment or treatment.
Thanks, Vanessa. So I'm just going to move on to the next potential area as well. At the end of the number of slides, we can go back if there's any particular areas you want to look at again. So moving on to children and young people, and just to bring in the potential caveat here when we're considering focus in this area, that it might be more relevant to go to overview and scrutiny that covers children. So that I'll leave that with you for further thought. But why and what in children and young people? So we use children and young people as the focus for the most recent DPH annual report, giving an extra plug to that if you've not had a chance to see it, and it's also available on the JSNA pages. That bit about new services, new specifications. So we started a new specification for our health visiting service in April this year with the same provider, which is RDASH. The bit about fixed term funding, there's been additional fixed term funding for family hubs in Doncaster over the last few years. That's been delivered through children's colleagues, but with public health input as well. Around compassionate approaches and wider and commercial determinants to healthy weight, and in the side there, Laurie shared in preparation for this meeting new data that we've got around NCMPs. That's the National Child Measurement Programme, one of those things that we have to do as a local authority, where we weigh and measure children at reception age and then at year 6, and what the change has been. So increase in number of children with who are not of a healthy weight when they're measured again at year 6. So a chance for us to describe the compassionate approaches, but also a new focus that we're doing as well around food and around a family food programme. And then just the bottom bit there, so South Yorkshire ICP strategy has got a particular focus on best start in life and school readiness as well. And I've included in the side there, I've gone through a few of the major stats for Doncaster, but why the panel might want to focus on a children and young people's topic for the year. I'll just check if anyone wants to indicate to come in on that. No, I'll keep going.
Excuse me. I'd already indicated I wanted to ask a question before about the health and well-being. Hi everyone, my name is Councillor Yetunde. I'm sorry for coming late. I got trapped inside the house. Well, it's regarding the demography for the health and well-being of women. I was just curious about, I know that you've explained a little bit about the access point where the assessments are done. Curious about different demography, if there's any, you notice anything. Also, how are they publicized? Because if I'm not sitting in this room, I probably don't know how this get publicized. How do we ensure that important groups are not excluded from this? Because I'm not sure if we are capturing everything. Thank you.
So I think the questions there about particular focus services for some groups of women. And Vanessa mentioned just earlier about the service that's provided by Changing Lives, and might be able to come in with some more detail about that as well. How is it promoted? For some services that are really specialist, will be promoted with targeted either promotions or probably more through relational type approaches, so either through peer supporters or through people who are able to introduce people to those services that might need them. The two services that I've mentioned, so for sex workers, we have, because we've got Amber Project, we've got a good understanding of who are the sex workers in Doncaster and what additional support and care they might need, including sexual health support. Similarly to Gypsy Roma Traveller women as well, we've got GRT workers in Doncaster that do most of their work through that relational type approach rather than advertise a service and hope that people will come. Vanessa, is there anything you want to add about Changing Lives?
A couple of things, Rachel, is one is Changing Lives and working with them around a women's hub and having a clinical space actually in Changing Lives in the city centre, and that's for women from different backgrounds to be able to, that maybe the women that Changing Lives work with are predominantly the women's centre that it was, predominantly people that may have not been registered with a GP, or they're not actually accessing services. And we do a lot of work with them around understanding why they're not accessing those services, but giving them the opportunity to actually have brief intervention. So it could be actually just, it doesn't have to be a clinical service, it could be something where it's a brief conversation around ensuring that they're aware of self-care and they're aware of when to actually access. And then the other work around Gypsy Roma Traveller as well is the health bus. So working with primary care Doncaster around having a health bus that goes around, and we're just looking at in the east of Doncaster having that access, so that there's the health bus is there for anyone that wants to come and not make an appointment but pop onto the bus and have a conversation.
Thank you very much. I'm just wondering if is what's considering faith groups, play groups as well, as a place where you can actually have access to this focus group, because I think a lot of people uses those groups. Thank you.
Yeah, so just to add on that again, a slide a bit later around inclusion health might give a bit more background and detail to this, but last year we completed and presented at Health and Wellbeing Board a health needs assessment for people from Black and minority ethnic groups, and that's on the JSNA website as well. From that, Dr. Victor Joseph and a group are working on an action plan for how to respond to that health needs assessment as well. So again, that might be a particular focus that this panel wants to add to the work plan for the year ahead. What is happening or what should happen for particular groups. We might want to include Black and minority ethnic communities or people within that as well. Let's keep going then. So I'll just hop over children and young people and go on to cardiovascular risk. So cardiovascular is a term that covers a range of conditions that can lead to poor health, but ultimately life expectancy as well. So within that would be coronary heart disease, heart failure, and strokes as well, and some other areas within that. One of the things that Public Health must commission is an NHS health check service, and we, for nearly 3 years, we didn't have one in place. We struggled to secure a service for Doncaster. This was through the COVID period. The team have worked really hard to secure a new provider that went live in February, and for the first time in nearly 3 years, we were able to report a number of health checks in March. So we've got started with that. And I know because a couple of you have contacted me about your either observations or experiences of seeing some of those health check services pop up in different different community areas across Doncaster. So that might be an area that the panel might want to consider, is how is health checks being delivered and what's people's experience of that. The health checks is a cardiovascular risk health check, so will include lifestyle type questions, but also measurements of things like blood pressure as well. And from that will give you a risk score or risk suggestion and make either lifestyle advice or referral signpost to services, including the Be Well service, so there's a connection in there as well, or might result in a prescription of something like a statin as well. So that's the aim and function of the health check service. What the panel might also be interested in is how that's working, so how that referral or take up, or have we got a wide enough breadth of offers beyond that health check service, and what do we know about people that take up that advice and either change their lifestyle or don't. So I would be particularly interested in that, but that might be a broader area that the panel might want to investigate and look into as well. I'll just check any questions on that. I have noted at the very bottom as well, so NHS Health Check is a particular offer, you should be offered that by the time you turn 40 once every 3 years. Obviously there'll be a number of people in Doncaster that haven't had that. For our service in Doncaster, because it hasn't been available for some time, we've been asking the service to focus on health inequality groups as well, but should apply as a service for all. I've noted at the bottom there that there's also health checks of a different type, but they do include cardiovascular risk for other people that might be at increased risk, including an annual health check for people with a learning disability and health checks for people with severe mental illness as well. So not NHS health checks, but other health check programs that are available to people. I'll just check any questions on cardiovascular risk. Okay, we'll keep going. And this is the one that I've given a bit of a heads up to as we've moved through the other slides as well. So inclusion, health routes and inequalities. And listed on the side there, I've listed particular health inclusion groups. We've mentioned some things that are currently available to sex workers in GRT communities. There's also people involved with the criminal justice system, people experiencing homelessness, and people with drug and alcohol dependence. And there's also a group that we describe under inequalities as well, so people that are at risk of having poorer health outcomes, either in accessing services, their experience of those services when they do get into them, but also the outcomes of them for all the reasons listed before and others. And that can be much poorer, significantly poorer for health inclusion groups, but also people from other groups as well. That you might have heard, you might not have heard, there's a core 20+5 type approach to health inequalities. And the core bit of that looks at people living in the most deprived communities, so the most deprived 20% of communities. For Doncaster, that's much higher, so about 1/3 of Doncaster people live in the 20 most deprived communities if we were looking at the UK data. But would also apply to ethnic minority communities, possibly people from LGBTQ backgrounds, people with learning disability and autistic people, people with multimorbidities, that is a person with 1 or 2 or more long-term conditions. So for example, if I had diabetes, but also another disability as well. And then also young carers and care leavers and looked after children. So these are the groups or the people that we need to think about more and additionally when either services are being designed or delivered. So I've mentioned just a moment ago that we've got the new Black and Minority Ethnic Health Needs Assessment and the Emerging Action Plan. So that might be an area of focus that the panel wants to take. And then in just a moment, I'll bring Vanessa in around the community health profiles. So these are a real tool for Doncaster, whether it's commissioners or service providers or yourselves in elected member roles, in that we've now got health profiles that bring together a real source resource of all the data and insight that we've got to understand what particular health needs or health wants or health experiences are in particular communities. And it might be that the panel would want to take an approach for particular named community areas as well. But I'll just check if there's any indications to come in on that. No? Okay, we are nearly there then. So my next one is a something else slide. I've then got a couple around Fairness and Wellbeing Commission, and then Vanessa will come in on that Well Doncaster community profiles. But what I didn't want you to feel was that I was nudging you in the direction of those 5 possibly broad areas. So I've just picked out from our JSNA pages other areas where Doncaster, I guess, is red, so Doncaster is not doing as well as other areas. So long-term health conditions, more than 1/5 of Doncaster residents have got a long-term health condition. That's the 5th highest in that whole Yorkshire and Humber region. And again, if that's a particular area of focus, we can bring more information about what's available, what people's experiences of healthcare services, and things like our peer support offer around particular long-term health conditions. So presenting that as a possible area. Respiratory diseases, particularly for a community like Doncaster, with some of the history around previous occupations. So respiratory diseases are a leading cause of premature mortality in people in Doncaster, and particularly people under 25 as well. And things like chronic obstructive pulmonary disease, or COPD, and lung cancer, including lung cancer mortality, are higher in that under 75 age group than they are in England. So respiratory diseases, either one or all, might be of interest to the panel as well. And then dementia, I know you had this on your work plan list for last year, and I've just included an overview there. For Doncaster, the diagnosis rate is good. I'll explain that because it sounds bizarre, but it's important for people with dementia to have a diagnosis because it opens the door and availability both to services and benefits and support for the family. So not the number of people with dementia being particularly high, but the diagnosis rate being high is something that we want to aim for to get people access to whatever the what next is for them. So again, dementia or recap on dementia might be an area that the panel wants to look into. And I'll just pause on that before I do my next couple of slides on Fairness and Wellbeing Commission, if anyone wants to indicate to the chair.
Yeah, thank you, Chair. Hi, I just want to ask a question around the impact of COPD, the impact of COVID on COPD, because, obviously these are people in the vulnerable category. Is there any plan of management, caring for people in this category? Thanks.
So that again could be a focus that the panel might want to consider more, but I'll give you my understanding from where I am now. So we've still got, you'll see, cases of COVID, and we still have people who are experiencing the impact of when they've had previous COVID infections, so otherwise described as long COVID, which is a list of, I think, more than 100 different effects on health, syndromes and experiences, so can include lung-related or cognitive and a whole raft of other impacts on people's health. As I've understood it, there is still a long COVID clinic. I'm not sure what the experience has been of that service. I'm just checking if Vanessa's had more of an insight. But, oh, you have? Oh, good. Okay. So there is still a long COVID support service, it sounds. I'll bring Vanessa in just a moment. Around the impact of people with COPD, so although we don't have clinically at-risk groups in terms of having to live their lives in a different way, the vaccination programme is still offered to what's now a more defined list of clinically at-risk people, not just COVID, but things like flu vaccination and other vaccinations, and support offered to those people too. I'll bring Vanessa in just a moment, but it might be that the panel wants to consider what the provision is for support for people with long COVID. But Vanessa?
Yes, thanks, Rachel. No, there's not a long COVID clinic, but there is a long COVID peer group. So a couple of years ago, as we moved out of into post-pandemic, Well Doncaster and Be Well supported a number of residents as a part of respiratory illness due to long COVID, and that's continued. over the last couple of years. We've now merged it into so it's no longer a long COVID peer group, it's a respiratory peer group, which is a mixture of different forms of respiratory conditions. But we still have a number of people that attend and want that support around that peer support. So it's not a clinic, but it is a method of ensuring that our residents have got somewhere to come. And as a part of that peer group, we ask residents what they are struggling with and what they need support with, and bring in clinical consultants when required. So we've had things like the respiratory nurse attend and a respiratory consultant attend those peer groups. But they also do like to have self-help as well. So we do have a number of different things around aromatherapy, reflexology, and things that are going to help them have self-help as well. So, but that's still running and still continues to run.
Thanks, Vanessa. And if long COVID is a topic that the panel would like to apply additional scrutiny over, we can do that preparation work to understand what else is available in Doncaster, if anything, can bring together the relevant professionals around that. Okay, are we okay to move on?
Yeah, thank you, Rachel.
No problem. So the next couple of slides, this was a huge piece of work last year, Fairness and Wellbeing Commission, both as an approach and the publication of the report and the recommendations, but wanted to include for the purpose of today all of the background work that was done on the data, so the data walks and the engagement. So used a mixed methods approach to understand people's lives and the impact of all sorts of different things on their well-being. So I talked at the start about how I was going to show you slides on lifestyle factors, access to healthcare and specific characteristics. The Fairness and Wellbeing Commission looked at the broader cause of causes, if you like, so income, education, social connections. We're often told that our health is a combination of our genes and individual choices, but we know that it's the places that we live and that we work and that we play and that we grow in that have the impact on us being able to have those building blocks for good health. So the purpose of including this really is to highlight to you that all of the data and the report are available to you as a panel to both develop your work plan, but also to provide that additional scrutiny or questioning around any of the topics that the work plan includes. And just from that, I'm presenting just some key findings that the report uses as well. So again, I've said, as I was introducing it, focuses on people living in more deprived neighbourhoods and impacts on the rest of life rather than just health. So that experience of providing care and living in poverty. Where that has gone is the findings and recommendations of the Commission have been sent out in a call and response type programme, and a number of them are in or being picked up by the Health and Wellbeing Strategy, but also by other partners and other strategy areas. So that's Fairness and Wellbeing Commission. I'll just check if anybody's got any questions, and then I'll go over to Vanessa for community profiles. No, I've got Al poised just in case there are any Fairness and Wellbeing Commission questions, but that's okay. Again, we can come back to it if we need to as well. So I'm just going to hand over to Vanessa then for community profiles, which has been another enormous piece of work for the year.
Thank you, Rachel. So we've talked a little bit about community profiles as we've gone through an appreciative inquiry. And if you're not aware, I lead on Well Doncaster, which is a new way of thinking around health and what does it mean around how we can ensure that residents' voices is a part of that health and things that make us feel well. And I talked about the appreciative inquiry and asking those questions around what does good health look like. It's around ensuring that local people are supporting local people to lead and develop the work that we do, and they're part of the solution and the answers to the work, because everyone should be leading on their own health, and that's we talked about community health as well. And also as well as ensuring that we have a community-centred approach and that we're ensuring that the services meet the needs of our residents in the best way we possibly can. We also want to celebrate the use of community strength and the use of communities, and we know, don't we? We know the term around that to support a child is a community that helps grow the child. So talk a little bit about the community profiles and what they do. They are a population health management approach to understanding what the health and wealth inequalities are. So it's driven by inequalities in place. And so we do have 88 communities across Doncaster, and so we have 88 community profiles. Some of them have had to be merged a little bit slightly just due to the population size has meant that we would have struggled to present something because some of them are a little bit tiny. But it brings data together around the insight of understanding what our communities are telling us, but also understanding it at a hyper-local level. It recognises a range of data sets that we've got from not just Doncaster Council, but from partners and national data as well. It actually covers 26 different forms of data set. It's a tool that is designed and delivered around supporting the health and well-being of our residents. And it's based on 3 kind of pieces of work. It covers health inequalities, and the health inequalities that it covers is around life expectancy, long-term health conditions, hospital admissions of all age, and also the cause of death, the childhood obesity, the alcohol rates in our localities, and also the smoking, and then understanding also around the family hub data that we capture. The wealth inequalities is around the deprivation, the employment, the food and fuel poverty that we have in our communities, and data from our Citizens Advice Bureau as well, as we are the local commissioner, housing data from St Ledger and across private rented as well, and the education data, and then also the community investment that we've got, so the different forms of money that we've accessed that are coming into our community, and also that vulnerable victim and antisocial behaviour, so that covers the wealth inequalities. And then we also have community insight. I normally kind of flip this, so I normally have community insight first, but it was the last side, so part of the slide. But those, whenever I talk about the community profiles, I like to talk about actually its assets in place. So it's got community assets. It's also got an understanding of people and the place. So when we talk about community assets, people often think about a building, but actually that rich asset of people is so important, and those activities. Understanding around the work of the appreciative inquiry, and then also Doncaster Talks, locality plans, and the pupil life size survey, and then again that community investment around that insight that we've been able to bring into Doncaster. So here's an example. I'm not going to go into the detail of the one-page summary, but here's an example. Armthorpe community profile. We have a snapshot at the beginning that shows you the Armthorpe and the 6 showing the inequalities in place. So Armthorpe and the children in poverty, the smoking prevalence and the respiratory disease, and then also the number of residents with long-term illness, and then a number of residents with no qualifications or lower qualifications, and then the impact of residents that are inactive. And then we also have a one-page summary, which I won't read out, but obviously it's there for you to look at, that you can absorb. It does cover demographics, but also the understanding of health inequalities in place. So what's next? So they're available on the Well Doncaster website. They're also available on Your Life Doncaster, so it'll link those over. We disseminate them across, so you're aware of bronze, silver, community based meetings, etc. So we present those, and we presented those, and we've also shared them, and they've also been picked up in many other kind of national arenas as a good place of practice. It informs our local, hyper-local regeneration work as well. So you've heard about that we've got 4 regen areas at the moment, which is Exthorpe, Highfields, Stainforth and Edlington, and we are going to refresh them in 2025, which will be about this time next year. We'll start to refresh them. It does take us about 6 months to refresh them, and so by the end we will get a republished by the end of 2025, and then there's just some links on the slide deck for you to go straight to them by your locality, by east, central, south and north.
Thanks, Vanessa. So I'll just check before we have our final slide, which is a summary, if anyone's got any questions on the community profiles to indicate. No? Okay, I think we're on to our summary then. So this looks similar to the previous one, possible topics all listed there, and we've been through each of those. And we've got our JSNA drivers gurus behind if there's any other particular areas of data that we want to pick into. So all 5 there. There's something else. Again, this isn't the exhaustive list, and we've taken you on a bit of a journey on all the data resources. So if you want to dig into those and there's something else that you're interested in, Yatunde mentioned long COVID. That might be something as a panel that you want to focus on as well. And then I've just added there as a reminder at the bottom that you usually receive the health protection report as well around March time. And I think you also have the winter planning one as well that comes before winter sometime as well. So leaving you with that as the list of possible topics, and happy to pick up either any additional questions or anything else that the panel wants or needs before it considers its work plan.
Is there anything anybody would like to say before
I'm just wondering, in terms of possible topics, I don't know if we can consider something around pregnancy, pregnant women, and nursing mothers, and all, breastfeeding, that kind of thing. Yeah, thank you.
Yes, so it might have sneaked onto the slide, it might not have done. But again, it's a South Yorkshire-wide group around improving maternity services. We've got particular roles, responsibilities, tasks in public health, including the health visiting service, making an antenatal visit. Other new things, I've mentioned the Family Hubs funding, so we have a breastfeeding support worker again for the first time who's been in post for it's just over a year now, and the Family Hubs receiving their BFI accreditation recently around breastfeeding. So certainly if the panel wanted to frame something around maternity services, we could assure that we bring you some of the data background that you need around that, but more importantly, staff and services that represent that journey for pregnant women as well. I'll just note the other responsibility area for us with NHS England colleagues is around vaccinations that are offered to women in pregnancy and just beyond pregnancy as well, and particularly been working on the whooping cough, which is a DTaP vaccination booster that's available. It's been available for probably more than 10 years now, but we've been trying to promote more considering the recent increase in numbers of cases of whooping cough. So if pregnancy, maternity or any element of that early years focus is something that the panel is interested in, we can help to work that up with you.
So I think we've noted the information that we've been given. I think the decision in our work plan was around substance use, drugs and alcohol. And I think if we looked at inclusion, health groups and inequalities, that could include some of the suggestions that have been made, and with a possible kind of focus on resources and evidence as a result of that focus, I suppose. And with a possibility for dementia, which we didn't get time to focus on last year, that we kind of promised ourselves we would look at. I think what we don't want to do is start off with a very long list and we then lose our focus. So I think if we take those things to start off with, that's a good plan for the next 12 months. Okay, thank you.
Yeah, so I'll just come back to respond in the affirmative for that. So I'm pleased, or I hope you feel that you've had a good journey through the JSNA and its products to enable you to make that work plan. Of course, if you get together as a panel and there's something that you either want to bring in through that work plan or focus on together, then we can move in that direction as well. But yeah, looking forward to bringing together the items around that work plan for you in the year ahead. Thank you, Chair.
Helps if you switch your microphone on. We're now going to look at adult social care in Doncaster and 2024 and progress to date.
Do you want us to introduce ourselves, Chair, in terms of...
Yes, that would be a good place to start, Phil.
So I'm Phil Holmes. I'm the Director of Adults Wellbeing and Culture in the Council.
Hello, everyone. My name is Glyn Butcher, person with lived experience and a carer, Director of the People Focus Group and also co-chair of the Making It Real board at the Council. Thank you.
Hi, Martin Walker, family carer of mum, 91 years old, lives out at Hatfield.
Hi, good afternoon everyone. Annika Leyland Bolton, Service Director for Adult Social Care.
Hi, Zach Martin. I'm the Autism Partnership Board Joint Chair. I sit on the Making It Real board. I'm a parent carer volunteer and a whole other laundry list of things as well.
Afternoon everybody, Kate Anderson-Bright. I'm the Service Director for Integration and Partnerships in Adults Wellbeing and Culture.
Would you like to start?
Yeah, sure, thank you. So I'm sitting in front of all these colleagues. I feel like I should be sitting alongside them, but everyone behind me and myself are part of Doncaster's Making It Real board. So Doncaster's Making It Real board, which Councillor Sarah Smith also attends, is a place where we together evaluate how adult social care is going in Doncaster and talk about and agree plans for the future year. So the paper, the paper that we've brought to you is basically sets out the way we work, describes what we've done halfway through this year, but also it attaches the document that was agreed at the start of this year that says what we will have done by the end of the year. So in other words, we're giving you a halfway report, and also I think maybe in a way that's complementary to the earlier item that we're kind of sad we weren't able to get here for. But you've kind of had a data and kind of inequality perspective. So this gives a kind of citizenship perspective in relation to adult social care, because as it says in terms of our vision, really, you can't do this stuff unless you're alongside people. So the vision about every person in Doncaster living in the place they call home, with the things and people that they love in communities where they look out for one another, doing things that matter to them. The Making It Real board is, well, supposed to be there to try and make that real. So in a minute, Glyn's going to say a few words, but Kate has been working closely with Martin on some parts of the programme, and Zach has been working closely with Annika on other parts of the programme, just like Glyn and I work together well as kind of co-chairs of the overall programme. So it's just we can dip into any questions that you've got depending on the nature of the issues, and just show you how we're working together, and also be honest, we've gone a fair way, but we've got a fair way to go even this year. But in terms of our adult social care journey, obviously quite a lot further to go in future years. So what the report does is it sets out the themes that your care and support, which is the document you've seen in the appendices, is structured into. It uses the Think Local Act Personal themes. Think Local Act Personal are a national organisation, so it means that we're able to talk about adult social care in Doncaster in a way that maybe will be familiar with people who live in other places. We're not required to talk about adult social care in these ways, but because Think Local Act Personal is an organisation led by older and disabled people, it gives us a structure that's not about us making it up. It's about areas or categories that are important to people rather than areas that are important to the council. We've in paragraph 12, you'll see it reflected in the actual document, in the actual appendix. We agreed on 9 areas that people with lived experience of adult social care wanted to see us progress further. So that's what we're kind of that's what the report updates you on. So the idea, which is top of the list really, that we increase opportunities for local people with lived experience of care and support to influence Doncaster's approach, from improving our services to recruiting the right people. So trying to get that influence across the whole of adult social care rather than it feeling symbolic or tokenistic. Getting a grip on information and advice, including advocacy, especially so that people understand their rights, because often people who come into contact with adult social care don't know what their rights are, so it's hard for them then to understand when about when they need to advocate for more or when they need to kind of speak up about the things that they need. Continuing to improve timely access to local to care and support, and we report quarterly on this. So our waiting times for assessments, for example, adult social care assessments and also access to OT, occupational therapy, have improved a huge amount over the last 2 years. So back a couple of years ago, you were talking about 120 days on average to wait for an occupational therapy assessment, and now you're talking about 2 days. So we've had significant shifts, but still quite a lot of work to do in terms of access on people's own terms. Especially, we've got a big priority that Zach and Annika are driving around employment, helping more people with a range of living in a range of situations, but especially older people, especially people with learning disabilities, but not limited to that group, and autistic people to access employment. So a big priority there. A focus on the support people get in their own home, but including people getting a direct payment, but also including people who don't choose to have a direct payment but need support in their own home. And a critical thing for us, because our performance here historically has not been very good, is helping more people leave NHS settings and be able to go back home again, rather than people who leave NHS settings and then maybe go into a care home setting. Now, probably no one goes into hospital thinking that means they're going to move to a care home, but too many people that happens to. So a really important priority to deal with that. Working on supporting our workforce, helping people have a good younger people with special educational needs and disabilities, having the right kind of support so that they enter their adult years feeling supported and having the full range of opportunities open to them. And last but not least, improving equality, diversity and inclusion. So in paragraph 13, I won't list all these because you had a chance to read them already, but you'll see across a number of those areas, you'll see the things that we've done already as a group, and the officers have done alongside people with lived experience. But you'll also see when you cross-reference with the Your Care and Support document, there's a lot of things still, we're halfway through the year, but it's a lot of things that we're yet to do and yet to complete. So as I say, Chair, we wanted to give you that kind of halfway opportunity. And as I said at the start, we feel like if we don't do these things together, we won't be doing them effectively. So maybe if I hand over to Glyn and give us a bit of feedback, Glyn, about how we've done that so far.
Thank you, Phil. Thank you, everyone. I think just say why I'm here first. I'm here for a voice of the people who can't speak out for themselves. I'm here for the peers with mental health, learning disabilities, in our care homes, in our hospitals, in our institutions, who haven't been given the opportunity that Doncaster Council, yourselves, have given to me. When I say co-produce, I really mean co-produce, because if I didn't say it, if I didn't mean it, I won't be sat here telling you lies. What we've done together has been unbelievable. The fact that we've been sat at the same table, being able to challenge each other, and we're still working in partnership, that's the testament to the strength of any relationship, because it's not always been plain sailing. But what we have done is come together to work on, to find solutions together and hear each other, not just listen, but hear. Actually listen and actively hear each other, and also then say what we think we've heard about health and social care, about homes, around people with mental health problems being employed within the council, around direct payments, around personal budgets, around many, 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 many different things where we've come together and we've created a pathway for solutions. I've also come along anomalies and bumps on the road, like any pathway, where we don't understand or we said no. And I think that's one of the greatest things about the Making It Real board, that officers are allowed to say, no, I don't know, rather than just make it up. Actually just be real and be human with people and say, right now I ain't got the answer, but what we'll do is we'll go away and come back with the answer to some of the problems that we're facing and see how we can create a solution together. That's really been different in a lot of the work that I've done. People know me anyway, I've been working this field for many, many years. But this is something really special, something really different in Doncaster. Something really special and really different in Doncaster Council that is leading the way for co-production, involvement, improvement, and also hearing its citizens, listening to the voice of its citizens and saying, you might say that, but that's not how it works in practice. Let's have a look how it works in practice and let's find some solution together. So that's why I'm involved. I'm involved in the Making It Real board because I believe in it. I feel it, I live it, I see it every day. And Peru together we make Doncaster, the people and the people's lives in Doncaster better. Thank you.
So other colleagues, well, I'm sure will come in later in terms of any questions that the panel have got, Chair, but we didn't want to just kind of go on at you a great length. We've done a relatively short report. The appendix, in terms of the Your Care and Support report, probably speaks for itself in terms of what we've said we're going to do. Just to be 100% clear, we are not here to tell you how great we are. So we're here to talk about the co-productions working well for us, and it feels like the right way to go. And there are some good experiences that people in Doncaster get through adult social care, but there are some that are not good. And our job is to take those good experiences and kind of scale them up and build on them. But we're not here to tell you that everything's great. It's just about illustrating the journey we're on, describing the work we've done so far, and being honest, as Glyn was saying a bit earlier, being a bit honest about how far we've got to go. So any questions, really?
I'd like to say something. I'm really pleased with the Easy Read report. That made my heart sing. And put your hand up, anybody on this side who read the Easy Read report first, because I'm here to tell you that that's the best way of understanding things. I absolutely love that, and I can see that makes Glyn really happy. Anybody who isn't a learning disability nurse will know that any reports that are in Easy Read, if you read the Easy Read first, you'll have a much better understanding of what's happening. And, you know, it's not just about people with a learning disability, it's about a whole raft of our community who struggle with the difficult things that we all get to read. And what we've heard this afternoon about health as well, and from you guys, is it's very difficult sometimes to access services when you can't articulate your needs. And as somebody who's spent many years as a professional, as a non-professional, when people are trying to ask you what you want, it's a totally different situation. And so I absolutely appreciate the fact that we've got an Easy Read report that I promise you, and I know, Phil, now we've done it, we'll do it every time, because that makes a huge difference to people when we're looking at what's been done and what hasn't. So I'm really grateful, and I thank you for that, and I want to see many, many more of these out there and in use for everybody.
Just a couple of things. First of all, I always read the Easy Read first, always, and sometimes I don't bother reading the rest of it. So 100% agree. It's a much easier way of does, you know, whoever you are, it's a much easier way of getting hold of information if it's done really well. Second thing is that when we talk about progress around advice and information, we're just about to we've just produced some information about rights, because as I said earlier, rights are the most important thing. I think it's often we act as if it's all complicated adult social care, but a lot of the time it's about basic human rights and asserting people's rights to things that maybe other people will take for granted. So we're just about to produce I think the technical name for it is a Z card, because it's one of those little things that is a Z when you open it up. So it's basically 3 sides of leaflet, but it's in easy read format, and it sets out the rights that people have in Doncaster and anywhere else around adult social care. So the rights that you would have just to have a conversation about the support that you need, and to be asked about what the most important things for you are. And then if you get to the point where that conversation leads to you needing support, the rights that you have around the nature of that support and its adequacy, and the choice you should have about it. And also connecting with your rights if you have problems with your memory or other aspects around your mental capacity. So setting all those things out in a plain English, easy read format, so that should probably help people in Doncaster as well. There might be other people behind Chair who want to, because there's all kinds of other examples they might want to highlight.
Thank you. I just on your point, Councillor Glynis. When most professionals tell me they'd rather read easy read version. But I think the thing to say about the easy read version, it's not just about producing a document. What it means to that person around the thoughtfulness and the being kind and caring, and that they've actually took the effort to listen and make an effort different to what normal communication styles. That's what resonates when people see an easy read, such as like myself and people from the People Focus Group and other voluntary sector. It means that actually somebody cares enough to change the way that they communicate with me. Thank you.
Are we good? Yeah, I'm a bit all over the place because I've literally just come out of work this morning, so my organisation's slower. I did actually, I had some notes on that bit about the using obfuscatory language and specialist discourse registering communications for people, as far as pretty much everything should be easy read to one degree or another. Because we spend a lot of time in meetings, and a lot of meeting time gets wasted on explaining systems and terminology that's in-house specialist discourse information, and so much time gets wasted on explaining these things. A lot of the time the staff themselves don't necessarily know what the system is or how it works or what the terms mean and the acronyms and stuff like that. So making more information more clear, absolutely a thing across the board. And because I do have that concern that we might be perceived as something of a hindrance sometimes because we don't know the Byzantine methodology of how things operate around here. We don't know how things work, and we don't know, we're not trained in these things. We're not trained in how to prepare reports and all that other nonsense, but you know, I don't know, liability stuff. So having that stuff more clearly laid out for co-producers in the first place would be incredibly helpful. Yeah, I think that covers that bit.
I'd like to make a comment on that. As counsellors, we could do with the same thing because we're not trained, you know. We get these reports, and you're absolutely right. They're full of acronyms and concepts. And if you were to stop the officers every time they mentioned something you didn't understand, the meeting would go on for 9 hours. It's very frustrating. I'm absolutely with you.
Yeah, some of that was, I was discussing it with Councillor Smith, for example. She said exactly the same thing.
And one thing we've produced again in the last month or two is a language guide for our staff. So I'm hoping that when you see adult social care reports come through, you'll start to see language that isn't about acronyms or jargon, but it is about kind of plain language, because as Zach was saying, really, our staff groups, ironically, our staff groups are quite plain speaking in day-to-day life, and the people that live in Doncaster are quite plain speaking in day-to-day life. So why we'd feel like we need to write long words and acronyms in reports just feels a bit. I can't speak for the rest of the council on that, but we've produced a language guide in adult social care, recognising that, and we've also said as well, when we develop public information for Doncaster people, and when we produce guidance for our staff about particular bits of practice, they ought to feel like they're the same thing, rather than something for Doncaster people and then a document for our own staff that's in kind of gobbledygook. And one final point, really important point, we're really trying to move away from language that's also kind of othering. So we're trying to move away, you know, the way sometimes professionals talk about service users or vulnerable people or complex people. We use weird words that actually we wouldn't want applied to ourselves, even though we probably do it in a well-intentioned way. So we're working really hard to make sure not only the language we use isn't full of acronyms or mumbo-jumbo, but is also respectful and things that we would want applied to ourselves, rather than pretending or acting as if the people that we work with are somehow different from us. So we're doing quite a lot of work on that.
We could make a stand, couldn't we? If nobody produced an easy read version, when they produce some of these documents, you don't accept it. You have to go away and bring one back.
I think that would be a really good stand. Yes, I absolutely agree.
I'm just saying, because councillors don't understand it like we do, so we're all in the same boat, aren't we? So just don't accept it and go away and come back.
So from that, I would confirm what we've heard, really, and we might discuss after the meeting what'll be included in our work plan, if that's okay. And there are no further questions, so I think I can. Yeah.
That's really helpful. Just to be. So at the back end of this year, we'll need to evaluate what we've done so far in the year, because we published a report and said we're going to do these things in 2024. So at the back end of this year, we'll need to check that we've done them, write down what we've done and what we haven't done, but also agree what we're going to do next year. So what we'll tend to do with that, if it's the same as previous municipal year, because this will be the third year we've done it, is we'll go to Cabinet and we'll say to Cabinet, here's how last year went, and here's what we're going to do next year. And like today, there's a space halfway through the year. If you wanted to, you could hold it to account in any way you wanted, but you could say, right, halfway through every year in Scrutiny, we are going to check that you're halfway through the year now. Have you got ahead of steam up and done things, half the things you said you were going to do? Are you a bit behind, or kind of what you're doing about it? So that could be something to think about, Chair. The other thing that's within the report that probably different from what the overall scrutiny function is obviously all ward members are community activists and are really closely involved with their communities and with the sorts of people that officers will be working with, but you'll be seeing them on an individual level and where they live, and in the communities, like the vision I described, really, where they look out for one another. So and there are opportunities if members want opportunities to get alongside some of this specific work around adult social care. So if anyone had a particular interest in home-based support or people accessing care or the right kind of advocacy being available for people, and they wanted to get involved in the work we're co-producing, it would be possible to do that. So that's the other thing, just to leave you with.
Okay. Okay, thanks for that, Phil. I think we'd kind of taken it as read as a scrutiny committee that we would look at the end of the year and see what had been achieved, and you know, because we're only halfway through now. So thank you for that. So I think we can close the meeting.
We've just got one more item, but officers can leave if they want.
Yes. Yeah.
Guests.
Yeah. So if officers and guests would like to leave, we've got one more item.
It won't take long though. It's just the work plan. I'll just summarise.
Thank you.
Hi, so as final item, it won't take long. It's just the overview and scrutiny work plan and council's forward plan. I'll start with the forward plan. Just to mention the main item, just to raise, is the health and wellbeing strategy, which is actually going to OSMC at the end of the month. So obviously you're welcome to look at that agenda and feed in any questions. Going back to the work plan, it was just an opportunity just to reflect over the meeting and see if I'm correct in what I've noted. That included in the work plan, where am I? So we've already got dementia and substance misuse. I'm going to add on inclusion and health groups and inequalities. And then from the second item to bring back, so you can see where it is at, the Your Care and Support item, and speak to members of probably the Making It Real board as well, and have that update. Is there anything else, Chair? Is that everything? Because we've also got public health protection at the end of the year, so you are getting quite a full work plan, even though it doesn't seem like masses of items. Is that correct, Chair?
That's correct, yes. So the meeting is now closed. Thank you.